Hi everybody, I'm Frances Johnston. I'm one of the General Trustees on the board of RCSLT and I'm chairing today's session. We are going to start with Emma Glisson from Oxford University Hospitals NHS Foundation Trust, and she's going to talk to us about dysphagia presentation, incidence and outcomes across subgroups of paediatric acquired brain injury. We're going to try and kind of keep to time, and then there'll be options for questions at the end. So please type your questions either into the Q&A, assuming that I'll be able to read them, or if not, I can definitely read the comments and I'll read out questions. I'll try and keep on top of that and read out questions at the end. Emma, over to you. Thank you.
If I could just have help showing my screen again, because I still don't have the button, but I think maybe Darren did something before that then popped up on my screen. Oh yeah, here we go. Thank you. Okay, can everybody see that?
Yeah, I can, so hopefully everybody else can. Fingers crossed.
Okay. That's great, thank you. So hello everyone, my name is Emma Glisson and I'm a speech and language therapist at Oxford Children's Hospital. I work in a specialist neurorehab team for children. I'm just going to give you a little bit of background just to kind of set the scene a little bit for my project. So Oxford Children's Hospital is a tertiary level hospital. So we see children from Oxfordshire, but also the surrounding counties who have severe brain injuries. We're also a major trauma centre as well. We have a dedicated neurorehab service. So we have a few years ago in 2016, we got a package of funding from NHS England to fully set up a dedicated service. So that meant that our neurorehab children weren't sort of prioritised against a general paediatric acute caseload. We are the team that provide their therapy. So typically we have relatively small numbers, but we see them daily, so they receive very high level input. So the project, kind of my motivation for this project came sort of when I started in the team. I did have sort of acute paediatric experience and brain injury experience from my acute work and a bit of community work. But really I didn't know what I was expecting in terms of the outcomes of dysphagia across the different types of brain injury. So, I started to look at articles and found that there are quite a lot of adult studies looking at brain injury, particularly obviously stroke and that kind of thing. But for paediatrics, it felt a little bit lacking. There were some really good studies that I did come across around traumatic brain injury in paediatrics, but my role kind of covers traumatic, acquired, and lots of different kind of infections, that kind of thing as well. So I didn't feel like I necessarily knew kind of what I was expecting for these children. And my motivation really came from not really having much evidence to base some of my decisions on when medical teams were asking me about when they would be able to take the NG out, or should they be referring for PEG, and also for families as well, wanting to know a little bit about how things might progress over the coming weeks and months. So when I started in the team, I started gathering outcome measures for all of my patients, and I kept a big database with a type of brain injury, how long it took them to get to oral intake, and outcome measures as well. So I wasn't necessarily planning on using this for a research project at the time. It was more just to guide my clinical decision making. But then I kind of recently started looking back on it and I thought this is definitely showing some trends now. And I really wanted to then look at it a bit more, analyse the data to really see if there were patterns and if that could then guide my practice better. So the design of the study is a retrospective cohort observational study. So all of the notes were kind of reviewed retrospectively, including the database that I was keeping anyway. So between February 2017 and June 23, we had 105 children who were referred to our team who had a severe or moderate to severe acquired brain injury. So within that, our age range was 6 months to 16 years. And we do see the kind of severer end, so the ones that require the intensive neurorehabilitation, so needing daily input really from each of the therapies. So that's kind of our criteria really for our team. Patients were excluded if they were then subsequently diagnosed with a different neurological condition or a pre-existing condition. So they were excluded because I couldn't then say that the dysphagia was definitely caused just by a brain injury. There were some who had incomplete data sets as well, and some had Guillain-Barré, which is more around peripheral nerves rather than a brain injury, so they were also excluded. So 85 children met the inclusion criteria. So we had traumatic, and then they were then categorized. So traumatic brain injuries, so things like falls, road traffic accidents, any sort of high speed injury. We had the vascular and the strokes, the bleeds, hypoxic brain injuries. So the children who had near drowning events went into that category, and also cardiac arrests. Under infection, we had things like meningitis, encephalitis, brain abscesses, empyemas, things like that. Autoimmune was those conditions such as ADEM and transverse myelitis, although that mainly affects the spinal cord, so it's more kind of the ADEMs and the autoimmune encephalitis. And then I had a few that didn't quite fit into those categories, so children who had loss of skills post-seizures, or who had hemispherectomy, so epilepsy surgery, and had a brain injury as a result of surgery, so they went into the other category. So I calculated the incidence of dysphagia across each of those groups, time taken to get to partial oral intake, and then time taken to get to full oral intake in days. And then I was able to calculate how many of those children in each of those groups went home fully orally fed, and how many went home without full oral feeding, so sort of PEG or NG feeding. So I used the functional oral intake scale as a measure of severity, and also as my primary outcome measure. So the reason I picked the functional oral intake scale is I did start actually using the TOMS initially, but I felt that I really liked the impairment and activity parts of it, but I found it really hard to score well-being and distress and participation for children who were on acute wards. It just felt really difficult to score. So I went for something that I felt like you could just sort of see the patient and very quickly see where they are on the scale. So levels 1 to 3 are tube dependent, levels 4 to 7 are having oral intake, but at varying levels.
Emma, sorry to interrupt you, but the slides aren't moving on for people. I don't know if they are on your screen.
They are on my screen, yeah.
Okay, it might be through the IT issue with Darren having to give you access. So if there's an obvious solution, we might just need to listen to the wonderful talk rather than necessarily getting the benefit of all the slides, I'm afraid.
No, that's fine. That's absolutely fine. Don't worry. I'll just keep talking. It might make a little bit less sense, but I'll do my best.
Okay.
So I looked at incidence across all of the groups, and I kind of calculated percentages within the groups that had dysphagia. So out of the traumatic category, 83% had dysphagia at admission. There was only 52% who had dysphagia in the strokes and bleeds group. 100% of the hypoxic brain injuries had dysphagia at admission. And then kind of 86% and 62% were the infection and autoimmune categories. But I think so I guess what that showed me is that 100% have dysphagia if they have a hypoxic injury. It's varying levels kind of across the other groups, but very high. The most interesting, I think, finding in terms of looking at incidence of dysphagia at discharge was the hypoxic brain injury group still had an 87% incidence of dysphagia at discharge from an acute hospital stay. So very, very high, whereas actually the other groups were much lower. So only 8% of our stroke patients went home with dysphagia, 33% of the traumatic brain injuries, 13% infection, and 25 autoimmune, and actually 0 of the other group went home with dysphagia. In terms of severity, using the functional oral intake scale, it was very interesting that actually the severity was very similar at admission across all of the groups. So there was a kind of, all of them scored around sort of 1 to 2, so very little oral intake, tube dependent, and I thought it was very consistent actually at the time of admission across all of the groups. So But interestingly, at discharge, it was very different. So most of the groups, so TBI, strokes, infection, autoimmune and other, were then, the mean was back to everyone was mostly fully oral, if you look at the mean across the group, but some modifications, whereas actually the hypoxic brain injury group still had very, very severe dysphagia at discharge. I looked at time taken to partial oral intake. Again, quite similar number of sort of days to get there. So in traumatic, stroke, infection and autoimmune, it was sort of somewhere between 10 and 20 days from admission to rehab that those children were able to have tastes or some oral intake that was assessed as being safe. It took much longer for the hypoxic group, so that was more of a mean of around sort of 35 to get to partial oral intake. And full oral intake, again, relatively similar across quite a few of the groups, but quite a big range. You can't see my graphs, but there is quite a big range in all of the groups, but the mean is kind of similar-ish across the groups. So again, for me, most interesting was looking at the outcome of dysphagia at discharge. So the children that leave hospital, what percentage still have, are fully oral at discharge. So 60% of our TBI patients were fully oral at discharge, over 80% of our stroke patients, over 80% for infection, 60% for autoimmune, and 100% of the other category were fully oral at discharge. Again, my most striking finding was that in the hypoxic brain injuries, only 12.5% were actually fully oral at discharge, and that accounted for 1 patient in that group out of 8. So my last couple of slides now, so I'm not sure how I'm keeping to time, but I will just do my last 2 slides now. So my main discussion point really from this project is around the hypoxic brain injuries. They have the most severe dysphagia and they are less likely to achieve full oral intake before discharge home. The 1 patient in the group who did go home orally fed had a much less severe hypoxic brain injury, so less downtime in her drowning event compared to the others. And I started kind of looking at, why is this? Why is there such a poor outcome in this category? And actually what I found is looking at the MRI results for these patients is that all of them have bilateral damage, prominently to the subcortical regions as well. So basal ganglia, thalamus, sometimes some cortical impairment as well. And actually looking through quite a lot of the adult research, there's more and more neuroimaging studies coming out about how our brains are actually, we have bilateral representation for swallowing skills in both hemispheres of our brain, but typically as individuals, we have one hemisphere which is more dominant, but that's not related to handedness, so it's not something that can be kind of predicted almost. But in some patients who have unilateral brain damage, there is the ability for the other side of the brain, which is primed to be able to function in terms of swallowing, to reorganize and start using that. So some neuroimaging studies have shown that kind of reactivation of other areas to kind of sort of plasticity, brain reorganization. Whereas one hypothesis for the hypoxic brain injury patients is that actually that bilateral damage, particularly to those subcortical regions which we know are so involved in swallowing, there's then very little ability for the brain to reorganize, it would be hypothesized, because both of the sides of the brain of those critical regions are impaired and are damaged. So I didn't use video fluoroscopy in these studies. I didn't feel it could be justified ethically or clinically. We had patients change so frequently, so it would have just been such a snapshot. But also the ones who did have severe dysphagia, it was very clear on clinical assessment. I didn't feel VF would have been anything I could have justified to further my understanding of their dysphagia. So in conclusion, I feel like this study has definitely provided me some basic data on the trajectory of recovery in brain injury. I feel like I have a better starting point for discussions with families and consultants and medical teams around where I expect or where I hypothesize their dysphagia will be going. And actually, it's definitely given me more confidence if medical teams are saying, actually, they're really not tolerating the NG, should they go for PEG? you know, for some of the categories now, I can quite confidently say we need to give them a bit more time. I'm confident that they will get there. We need to give more time. Whereas actually, if it was, say, a patient in the hypoxic brain injury group, I feel like I could justify more around why that would be a good thing to do earlier on to support NG removal, because I know that that dysphagia is much more likely to be long-term. So that's me finished. I'm very happy, obviously, to take questions when the time is right at the end of the presentations. Thank you.
Thank you very much, Emma. That was great, really interesting. And thank you for kicking us off this morning. Just looking at timing, everybody, the next keynote speaker is at 12. So I think what we might have to do because of the delays is ask you to message your questions directly to the speakers if you have any, for them to be able to respond there, I'm afraid. Also, the Q&As just aren't showing for me. I keep getting alerted that you're adding things to the Q&A, but I can't see any of them, I'm afraid. So I think because of timing, that probably makes most sense so that we can then join the next keynote. We did have Julie, but she's just gone off the screen. Oh no, she's back. Julie, are you able to hear me? Can you hear me, Julie? Oh.
Hi, yes, I can hear you.
Oh. Excellent. Are you happy to? A bit of feedback there. I'll take my microphone off in a second. Are you happy to go next? I'll take my microphone in a second. Are you happy to go next?
I don't see that Sharon is on.
Okay, she messaged saying that she was in the room somewhere, but yeah, she's not showing, is she? So she's on, she's trying to join the meeting. Should we go then to Casey if you don't mind? Should we go then to Casey if you don't mind?
Yeah, I can do that.
Brilliant. So Casey is going to talk to us about swallowing and oral sensory motor skills of young children with severe acute malnutrition. Thanks very much, Casey. And then hopefully that gives time for Sharon to join over the next 15 minutes or so.
Yeah, no problem. Okay, there we go. I managed to get my camera on. Okay, so hi everyone. My name is Casey. I am a speech therapist and lecturer at Sefako Makgato Health Sciences University, and that is in South Africa. This research is part of my doctorate that's completed with the University of Pretoria in South Africa, my strong alma mater. So yeah, our background to why I embarked on this study is just an experience that I had in the hospital and what was happening with the doctors in terms of referrals. And also I found myself questioning why I never mentioned this population when I explain what I do. So as a speech therapist, I ask all of you, when someone says to you, what do you do? How do you help swallowing? What do you say? Like when you say, yes, I help children with swallowing difficulties such as, what populations or diagnoses do you mention? So for me, I realized that I never say malnutrition. I never say underweight. I never say malnutrition. And I found myself realizing that it's because I usually put it into a category of being underneath HIV, underneath CP, underneath neurological difficulties. So it is something that I realized maybe we should be looking at this on its own, because in Africa and Asia, there are many children that have no other diagnosis. It's just malnutrition. So for those of us who need a bit of a medical review because maybe we're not so familiar with the diagnostic criteria, SAM, or severe acute malnutrition, is specifically the most life-threatening form of being underweight. So according to the World Health Organization, that is children who are more than 3 standard deviations below their weight for height in their growth chart. So that's below the black line. And then it can be characterized by severe wasting, nutritional edema, and a mid-upper arm circumference of less than 115 millimeters, so less than 11.5 centimeters. That's crazy small. And yeah, it's really alarming that 1.3 million children in sub-Saharan Africa are experiencing severe wasting, and it's associated with motor and cognitive delays, but there's not much that we as speech therapists are doing about this because it's a population that is not mentioned when we are doing literature reviews. It's not mentioned when we are doing training and teaching in our undergraduate and postgraduate degrees. So this is a population that at this point we might be overlooking. So research has been orientated specifically towards a medical approach. So that is looking at survival rates and nutritional outcomes. However, in the last 5 years, health research has said, okay, great, we need to actually switch across and say, what are we doing in terms of rehabilitation? How are we supporting children's developmental outcomes to ensure that they have a positive future and can participate in society? It's great that we've done this research that's medical and we have survivors, but what are we doing to help our survivors? So what we do know about SAM, moving too quickly. So what we do know about SAM is that longitudinal studies have shown children present as weak, hypertonic, and lethargic. And that behavior is causing them not to engage with their environment and is probably contributing to the long-term cognitive and motor delays. But we as speech therapists know that children who have got motor delays and children that have cognitive delays might have impacts on their swallowing because swallowing is voluntary and controlled by very complex cognitive processes. So why don't we have the description of oral sensory motor skills development in children with SAM? With SAM, we also know that food refusal is even a diagnostic criteria. We decide if a child should be admitted to hospital or managed in clinics with their malnutrition based on food refusal. It's called appetite test. Home-based observational studies have also shown us that children with SAM have reduced appetite and high rates of food refusal. And research with typically developing children have noted that increased food refusal may be associated with underdeveloped oral sensory motor skills. But we still don't have the description of oral sensory motor skills development for children with SAM. So, a very recent case study of 3 toddlers presenting with SAM, HIV, and TB in South Africa has identified that all 3 toddlers presented with heterogeneous oral sensory motor difficulties. And those difficulties were impacting oral and pharyngeal swallowing phases. And so because of that, that was our motivation to now have a look and say, what are the oral sensory motor skills of children with SAM? So we specifically were looking at children aged 6 to 36 months during the rehabilitative phase of nutritional recovery. So this is when they're out of life-threatening stages, they are considered medically stable, and it's when the doctor would typically involve the medical rehabilitative team. So a busy slide. What we did is we used a prospective comparative design, and we identified participants who were hospitalized, children diagnosed with SAM, 6 to 36 months, and their caregivers needed to understand English, because I am just English and I don't have another language to use. So we selected them proposively from 3 tertiary hospitals in Tshwane, which is Gauteng, South Africa, and we did their bedside assessments. After that, we identified the control participants matched according to very specific criteria. Geographic location, age, gender, TB and HIV status, because it does have an impact on recovery, as well as socioeconomic factors of maternal education, paternal employment, housing status, transport access, as well as their monetary socioeconomic status. And this close multi-factor participant matching that we have is a significant strength of this study. We got ethical clearance from University of Pretoria, as well as all hospitals and clinics necessary, and the data collection took us 7 months. So In that time, we identified 52 participants. However, we had to exclude 7 due to participants with SAM, and we had to exclude 7 due to their presence of developmental disabilities. So in the end, we had 45 participants. We did a background interview and corroborated the information we got from the caregivers with their medical files and their Rhodes Health books, which is like a clinic book in South Africa. And then we followed that with a communication assessment, which is part of a different research article. And then we did a feeding and swallowing assessment using the schedule for oral motor assessment. This focuses specifically on oral motor characteristics across multiple consistencies of puree, semi-solids, solids, like crackers or biscuits, and then liquids, breastfeeding or bottle feeding, and an open or trainer cup. So that was really valuable in terms of being able to describe the oral sensory motor characteristics in the population. Due to the subjective nature of this rating, we did have a second rater who evaluated 15% of the sample, and strong scoring agreement was shown. So our participants were 45 children with SAM paired with their control group, according to all those crazy cool criteria. And so we have a total sample of 90 45 pairwise matched children. The average age of participants was 16 months and 55% were male. 60% of our research group were participants that were exposed to HIV, and 51% were confirmed as HIV positive. And that is a really high rate. This does align with other research from the Eastern Cape in South Africa, and it highlights their lack of access to family planning, healthcare facilities, poor preventative medicine, really poor adherence to PMTCT guidelines. And that shows why we need to help these children early on, because if they're not going to follow instructions and medical advice at home, we need to give that before they leave the hospital. In addition, we had poor housings and poor sanitation considerations, and that aligns with previous research, as well as poor access to personal transport. They rely on public transport, which is another thing that can impact on prevention and promotion strategies in healthcare. Interestingly, all the mothers that we found had an average roundup of 10 years of education, which means they're not finishing their education in South Africa. And the majority of the caregivers, control group caregivers, were mothers, whereas the research group was mothers, grandmothers, and extended family. And that's quite an interesting, striking difference for us, because they all come from the same similar contextual factors, but the control group, who don't have SAM, are cared for primarily by their mothers. So, getting into our feeding results, we had a lot of reports of disruptive feeding behaviors in both the child and the environment, and that highlighted for us the interplay of feeding practices and malnutrition resulting in this severe acute malnutrition outcome. It's not a one-directional transaction. There are multiple factors playing in different directions with these children. They're an extremely complex population. Significantly more children in the control group were ever breastfed. There were similar rates of breastfeeding, but a shorter duration of breastfeeding in total in the research group, and most of the research group was also bottle fed. In terms of complementary feeding practices, we had an interesting result here because less of the research group participants were introduced to complementary feeding, and that indicates late start of complementary feeding and possibly missing the developmental window. This also further highlights the possibility of having underdeveloped oral sensory motor skills as well. And that is contrasting with prior research, because prior research on risk factors is often showing early introduction of complementary feeding for children with SAM. So this is late introduction and possibly missing the developmental window. And then significant disruptive feeding behaviors were giving sweets in addition to food and force feeding. The majority of the control group were refusing food towards the middle or end of meals, which is expected. However, the research group majority were refusing food in the beginning, which is also aligning with previous research from dietetics perspective. Woo, there we go. So in terms of oral sensory motor skills, across all the consistencies except for liquids in trainer cups and bottles, 25 research group participants, which is 56%, presented with significantly more oral sensory motor difficulties across most consistencies, and that compared to only 6 participants from the control group. So 25 in the research group, only 6 in the control group. 53% of our research group, children with SAM, presented with neonatal feeding difficulties, for which only half ever received speech therapy intervention. Notably, there was no speech therapy involvement since the participants' neonatal period, and no specific swallowing disorder was provided as diagnosed before the data collection occurred. So no speech therapy involvement. And that shows a significant lack of continuity of care, which we really need to pay attention to. So in terms of specific oral sensory motor dysfunction, we had very similar results to the previous case study, showing difficulties with oral preparation, specifically graded jaw opening, stabilization, removing of food from the spoon, tongue protrusion during bolus preparation, and poor lingual control in general. Sustained bite was not sufficient, and there was poor lip closure. There was anterior food loss in multiple participants and very poor mastication if they were able to bite through the biscuit that we were giving. Then there was also food pocketing and multiple swallows to clear during the pharyngeal phase. And then, yeah, clinical signs of aspiration included facial grimace, wet vocalizations, gagging, coughing, and choking, which all highlight that significant risk for oropharyngeal dysphagia. So to round up, we have presented very novel description of a high percentage of oromotor difficulties in young children with SAM, and this bridges that knowledge gap and underscores the importance of safe swallowing for this population. We need to ensure that they have good health and nutritional recovery once they are discharged. And the under-identification and lack of referral to speech therapists really highlights that lack of continuity of care and emphasizes why we need to continue research with this population. We need to really explore it so that we can inform our practices in healthcare worldwide. So we really do need some continued research on oral sensory motor skills, but also something that wasn't covered in this research was the pharyngeal phase of swallowing specifically. We've observed clinical signs of aspiration and risk for oropharyngeal dysphagia, but more research is definitely needed. So that is my take home. Thank you so much, everyone.
Thank you very much, Casey. That's brilliant. Again, really, really interesting talk, and thank you so much for bearing with us. And thankfully, the slides did move during your presentation, so that was great. In terms of
so much.
Thank you. In terms of the final presentation, Sharon and Julie are both with us. Sharon can't get on to the presenter bit, but actually it's been pre-recorded. So I understand that Stream 7, who are the platform people, will play it for us any second now. Please, also just a reminder that please do submit questions directly to the speakers, because we're not going to have time to go through questions, unfortunately, before the next keynote. And also I have just had it confirmed that you will have access obviously to the recordings, but also to the slides, and the conference organizers will either let us know on this platform or we'll email out to everybody to let you know how to access that information. So hopefully Stream 7 are now ready to play the pre-recorded presentation from Sharon Spicer and Julie Evans. Fingers crossed. I'll give them a second. Let me type something in the help section just in case. I suppose Darren can't hear me. He seemed to be able to pop up every time I said his name earlier. Let's give it a minute and see if they come on. I had been emailed to be was assured that it would be played. Let me just send a quick email. If we can't get it playing now, then it will be available as part of the other pre-recorded presentations. So you will definitely be able to access it if we can't do it on now. Is that somebody joining that's able to stream the presentation?
Hi, it's just Julie, and I just wanted to encourage people that if we're not able to stream the presentation and with Sharon not able to join the platform, I think we'll plan to just have the pre-recording available on the platform, and just want to let people know that in our session we're talking about how pediatric eating and swallowing, about a project to transform care for children with pediatric feeding disorder in the province of Alberta, Canada, over the past 3 years. So we had some really exciting results around a quality improvement initiative that was province-wide, and encourage you to check that out if we're not able to share it this morning.
Great, thank you, Julie. Darren, are you able to stream the presentation, or will it be available for people after the conference? Oh, here we go. I can't hear anything, Darren. I don't know if anybody else can.
I might always be coming through, Tom. Well, I'll be a bit disturbed at everyone. This is shortly.
Sorry, Darren, I didn't catch that.
Hi, let's just try and get a screenshot of it for you.
Thank you.
I think we've got it. Might be one that your 8 should be working middle 9. Oh, okay, it's not telling us on yet. If I do Jess, kind of Jess.
Sorry, Darren, I'm having trouble hearing you.
That was something I was just about to ask. So I've got Nazia first, and that's the start we've got.
I'm wondering, so that we aren't able to watch it just now then, is that what you're saying, yeah?
Hello. Today we will show how a pediatric eating and swallowing project has been transforming care for children with pediatric feeding disorder in the province of Alberta, Canada, for over 3 years. Pediatric feeding disorder, or PFD, is impaired oral intake that is not age appropriate, lasts at least 2 weeks, and is impacting medical, nutritional, feeding, and/or psychosocial functioning. It is estimated that 1 in 37 children have pediatric feeding disorder. I'm Julie Evans, and I'm here with Dr. Sharon Spicer. We're both members of the PEAS leadership team. We have no financial disclosures. Photos of the children in our programs are used with permission. As we share our learnings, we hope you will also identify opportunities to engage families and stakeholders in quality improvement, to use the innovation learning collaborative approach, and to recognize improvements in children's and families' care experiences. We look forward to sharing resources that are available to you and to the public. In Alberta, we needed to do better for children with PFD and their families. Thus, we advocated for grant funding and instigated a powerful collaborative effort, the Pediatric Eating and Swallowing, or PEAS project, a quality improvement initiative to standardize and improve care. We're grateful to live and work in the territories of the First Nations, Inuit, and Métis peoples of Alberta, Canada. Alberta has roughly 6% of the population of the United Kingdom, spread across almost 3 times the land mass. Population is extremely sparse in the north. Alberta is unique even in Canada in that we have one publicly funded health service provider for the entire province. Through this single system, we attempt to address disparities, including highly variable wait times, the need for some families to travel long distances to access care, and limited access to interprofessional care, the gold standard for managing PFD. There were discrepancies in clinicians' training and confidence in addressing PFD, with reduced ability to specialize, to connect with, and to learn from one another. It was a challenge to engage individuals and teams from across our vast province, yet we persisted. First, we hosted World Cafes, discussing what was working well in care and what was not. Families valued the chance to share their concerns alongside physicians, managers, and other care providers. These are some of the comments we heard. Concerns centered around communication, access, role clarity, training, and providing patient and family-centered care. For example, including families in goal setting and acknowledging the emotional impacts, cultural influences, and family dynamics associated with feeding and mealtimes. Themes were mapped onto Michi et al.'s behavior change wheel, and families and staff validated 20 intervention strategies to ensure that we were on the right track. You can see our timeline here, progressing from baseline evaluation and resource development to ongoing engagement and training, then integrating strategies and resources into day-to-day care. We developed a structure and working groups to address access to care, quality of care, equipment and supply issues, provider roles, and to demonstrate how improved care impacted both families and the health system. Over 1,000 family voices informed every stage of our work, fostering connection and compassion and reinforcing the importance of the work. A pool of advisors provided input through interviews, focus groups, surveys, patient journey maps, and a family advisory council. We developed a number of resources, including a clinical practice guide, information for families, and professional development webinars. We are especially proud of our website, peas.ahs.ca. Here you can access the resources referenced in the previous slide and many more. Now, Sharon is going to tell you about our implementation tools and strategies, our data collection, outcomes, and plans for sustainability.
As part of our QI process, we use the Innovation Learning Collaborative, or ILC, of Alberta Health Services, a methodology adapted from the Institute for Healthcare Improvement to identify and implement clinical best practice. We hosted 4 virtual ILC workshops over 2 years. Together, interprofessional teams and families identified goals and created action plans. Teams implemented their changes and collected data with access to support such as coaching and educational webinars. We used the 6 quality dimensions as defined by the Health Quality Council of Alberta to guide our selection of domains. Within these 6 dimensions, we identified 8 key performance indicators, or KPIs, that each team would measure over time. We won't describe them in detail now, but they are available on the workshop slides and on the PEAS website. We then used the KPIs to create balanced scorecards to measure performance. This is a QI approach that uses multiple measures over a period of time to ensure that making improvements in one area does not lead to unintended adverse effect outcomes in another dimension. This is an actual scorecard from one of our teams. The measured outcomes in each KPI are shown in green. You can see each one rose from a baseline of 3. None fell below the baseline. The aggregate score at the start is 300, and in this case, improved to 680 out of 1,000 over 18 months, showing that the overall outcome had improved. This is a QI tool showing improvements over time across the province. This chart shows the changes from spring of 2021 to the fall of 2022. Across the very bottom are arrows showing the direction of the desired outcomes. For the measures of acceptability on the far left and accessibility on the far right, we did not see significant change as the baselines for these measures were already very high. For appropriateness, effectiveness, and accessibility, you can see statistically significant, steady improvements over each quarter. In the middle 2 columns, we see efficiency and safety. Both of these measures improved. One other KPI, accessibility, did not show significant change over time. In addition to measuring KPIs, our multi-pronged evaluation approach included gathering qualitative and quantitative feedback through surveys and focus groups for families and providers. Here we show a survey of our healthcare providers. They reported feeling more confident to access resources for patients with PFD, that access had improved for consultation and instrumental assessments, and that care was more coordinated and access to information was improved. The PEACE project was a complex and comprehensive undertaking. We brought together providers and families from across a diverse province. We continue to operate even through the challenges of COVID and our implementation of EPIC. From the outset, PEACE focused on teamwork. Communication was critical for engagement. We were particularly intentional about including families at every step. We benefited from emerging technology, including virtual platforms during the pandemic. And finally, we celebrated successes and were the recipients of multiple awards. As with any project, we faced some challenges. First of all, the COVID pandemic made data collection a challenge. Staff and families faced fatigue and burnout, and that probably made it more difficult to obtain survey results and feedback. We also found that families that were not directly involved in our quality improvement project did not know about the resources that were developed. So a key step for us is ramping up our dissemination strategy. Finally, an ongoing challenge and opportunity for us is sustainability. We received grant funding for the QI project, and now we are aiming to sustain change in regular operations. We've created a community of practice. We provide professional development opportunities and keep our tools and guidelines up to date. We have ongoing monitoring for continuous quality improvement. By sharing our experiences, we hope to encourage you to use QI methods to improve your eating, feeding, and swallowing practices as well. We're happy to share our resources. We're available for questions and would be happy for you to connect with us.
I'm not sure if you can hear me, everybody. Trying to get the camera back on. But thank you so much to Sharon and Julie for that presentation. I'm really pleased that we were able to see it in the end, and what a wonderful collaborative project. That was really fantastic. Thank you. For all of the presentations and the slides will be available after the conference. Please do send your questions through to the speakers directly for anything that you would like clarified or any discussion you'd like to have with them. I'm going to end now so that we can go back to the next keynote speaker, which I believe is from now until 1 o'clock.